Hello, everybody. Welcome back to the Incubator Podcast. We are joined by two new attendees to the CHNC conference, Jonathan Levin and Kristen Leeman. Kristen, Jonathan, welcome.
Thanks. Happy to be here.
Can you tell us a little bit where you're coming from, your city institution, and what is your role at your current institution?
Sure. So I'm Kristen Leeman. I'm from Boston Children's Hospital, and I'm the Associate Medical Director there and the Director of QI and the Program Director for the Harvard Neonatal Perinatal Fellowship.
Very cool.
Well, it makes sense why you're here today.
Yeah.
What about you, Jonathan?
And I'm John Levin, also coming from Boston Children's. I'm actually a dual-trained neonatologist and pediatric pulmonologist, so I help run our BPD program up in Boston. I do both the inpatient and outpatient side, and I came to the BPD colloquium that was just over the last few days, and here for the rest of CHNC as well.
And you're part of the BPD Collaborative. I feel like you're presenting cases at the BPD Collaborative very frequently. I feel like whenever there's a gap, they call Jonathan and be like, Jonathan, present something.
See, you two are very interesting. You have very interesting roles, and you almost didn't let us interview you here today. So,
A little microphone shy, I guess.
So, is this both your first time being here, the CHNC?
Yeah, this is my first time at CHNC, and I really was drawn because of the BPD session, the pre-session. I was able to give a couple talks about BPD and QI, and really some of the issues with how do we define success in BPD, and can we move past death and tracheostomy as our outcomes? Like, how are we defining the complex care we're doing?
This is something that people have been talking about redefining the outcome so that it's not some of the crudest outcome possible. It's like a dead or alive, and we can actually move past that and get to maybe optimization of our baby's outcomes. I'm just curious, what are some of the takeaways of the talks that you've given?
Yeah, I mean, we had a breakout session where a lot of the experts in the room were able to talk about potential projects that we could collaborate with across different hospitals, and people had amazing ideas. Some of the kind of interesting points and discussion points were like our use of neurosedatives and what are we doing? How can we reduce the use of IV sedation? How can we optimize developmental care? And how does that all interplay?
I feel like for BPD babies specifically, Jonathan, tell me what you think. I think that we used to, way back when, use a lot of restraints on these babies so that they wouldn't pull their tube out and stuff. And we've moved away from restraints, physical restraints, because obviously that is not the right way to go. But we've then moved to sedatives. And I think they act as pharmaceutical restraints almost. So it's interesting that you guys are picking on that.
Yeah, I think in the last few days, a lot of focus on getting babies into their sort of right interactive state and right developmental state. These are chronic patients who are there in the NICU for a long time, and really sort of reframing how we look at them is not just these ICU patients, but rather these infants that are trying to go through somewhat normal stages of development, and how we can best support that. As Christy said, there was a lot of discussion on what the outcomes we should be using, and I think even with that same idea, it's this idea of tracheostomy and death is this outcome that's been historically being used in a lot of clinical trials in neonatology for understandable and good reason. I mean, I think that it's no one sort of starts out the course sort of hoping for a tracheostomy. We understand that, but also realizing that on the note of developmental success, sometimes tracheostomy is really the best way to get there, and it really shouldn't be viewed as a failure, but rather as a means to achieve the best cognitive and developmental outcome possible.
Yeah, it's interesting that you bring up this point about specifically tracheostomy, which we see as kind of a worst case scenario, but maybe it's not. And I understand a lot of the discussion we didn't get to attend focused on how do we partner with parents in some of this decision-making capacity. Yeah. Any thoughts about that?
Yeah, I mean, I think that parental reluctance is a huge barrier to overcome. So we did a lot of discussions about when to start the conversations about potential need for long-term ventilation, and how tracheostomy is a step towards that chronic care model, and kind of really focusing on developmental care. But parents are hesitant, and rightfully so. They're scared, and different ways to get their questions answered, get them connected with other families that have been through the same circumstances, and how do we overcome some of the disparities related to their maybe inability to visit, inability to ever take the baby home in some cases. So, their reluctance is understandable in some of those cases. And how do we help families through this and do the best things for the baby at the same time? It's quite a challenge.
Yeah, absolutely. I mean, we started introducing the discussions very early on when it comes to the diagnosis, and then introducing the discussion about tracheostomy as early as 36 weeks, just so that we can all be on the same page when the time comes around 42.
Yeah, no
actually,
surprises.
John has worked on a predictive calculator to try to help us, how do we know early on, these babies are, 99% likely to need long-term ventilation, so let's start the conversation earlier, get the trachs in earlier, so then we can decrease the IV sedation and get them, involved and engaged with their developmental care.
Right. And that was certainly a theme over the last few days is again, recognition. BPD is diagnosed at 36 weeks historically, and sometimes I think both as a reflection of kind of our, as neonatologists, our view, and we don't want to sort of view things as a failure, and we want to give babies the chance, but really recognition, well before that even point, that this is a chronic disease, and I think the earlier we recognize that infants are transitioning to that chronic state, is the more we can support them in that way to kind of get to the optimal respiratory and developmental outcomes.
Because we know tracheostomy early is better, but when that is still a question mark, right?
Yeah.
We and even we say that we don't, there's no randomized trial that's going to show that. It would be impossible to design that trial of looking at, or near impossible to design that trial looking at timing. But I think the way we generally look at it, and there's certainly some observational papers that support this, is that if there's an infant that's going to require long-term support, particularly in the form of invasive ventilation, where you're going to require neurosedatives over time to keep them safely intubated, you're getting them on the pathway towards recovery and more normal development, and probably most importantly, trying to get the infant home, right, by doing that sooner. And it's really hard to get all those processes started sometimes, before, or you're somewhat limited, I would say, sometimes when, you're having to sedate the infant to keep a breathing tube safely in. And I think that's sometimes the advantage of doing a tracheostomy on the earlier side.
All right, everybody's wondering the same thing I'm wondering. Where's that tool? Can I use that tool, that predictive model?
We are refining the statistics now. It should be hopefully getting submitted for publication over the next few months.
You heard it first on the incubator.
That's right. Very exciting. Very exciting. Well, it's obvious y'all have an interest in BPD. Are there other things you're looking forward to or hoping to achieve in the next few days to take home with you?
I think John's going to go to some hikes and go on the mountains.
There's definitely that as well.
Equally important, right?
I don't think we're supposed to say on the podcast that we're cutting the conference. No, but
you mean after
the conference, obviously.
From 7 to 9 p.m.
No, I think also just this idea of being able to, we were just talking about this on the way over here, about sharing data and really being able to use it for, we both work in a level 4 NICU where we take, care of some pretty rare conditions, right? And to sort of be able to track meaningful outcomes for these on an individual level gets really challenging, right? Because even things that we see with relative quote unquote frequency can still be pretty rare overall. And I think the chance to be able to say, all right, this is how we can leverage, all these sites around the country of contributing data for these rare cases, when you put them all together, these things, they're still rare, but you actually have a meaningful number, and it's a way to meaningfully say, for whether it's, gastroschisis or myelomeningocele or things that are again, that we don't have great outcomes necessarily to track, to sort of keep make sure that we're still on the ball of saying, all right, what are the outcomes we're seeing? How does our NICU compare? Are we seeing changes over time, good or bad, and how can we improve those?
We were talking about using the power of CHNC and CHND database to expand our dashboard and include some of these more rare conditions that we have a handful of, every year, and what should we be following? How are we comparing our performance at our individual center with the larger group, and are there opportunities in some of these to target quality projects related to the care of these babies? So it's really powerful when everyone gets all their data together, that you can really improve care and share best practice, and it's exciting for that opportunity.
Thank you guys so much for being on the podcast.
Thanks.
Thanks for having us.